Thank you very much for Dr. Phillips and the organizing committee for this invitation. It's really honored to present you this talk of how to understand your pathology report. I know you may have interaction with your physicians, but you probably don't know who signed out your pathology report and how to best read your pathology report. So here's three pictures. This one had the monitor, had the lab, this one had the tube, and had this culture dish, and this one is looking at the microscope. So you are probably wondering which one is pathology. Actually, all three are pathology. Pathology, we have a wide spectrum of disciplines, including anatomic pathology, clinical pathology, and forensic pathology. You're probably most familiar with forensic pathology from TV shows. That's only a portion of pathology. Anatomic pathology, I'm an anatomic pathologist. So we make diagnosis on tissue samples, such as biopsy, finding aspiration, surgical specimens. We also have clinical pathology that include all the lab works, including chemistry, blood banking, microbiology, molecular pathology, hematology, and immunology. Of course, I will focus on anatomic pathology in my today's talk. Huang Rouzai is a pathology legend. He wrote this very famous book in pathology world, Guiding the Surgeon's Hand. In reality, we're probably the best friend of surgeons in terms of patient management. We really try to work with surgeons to be a critical part of the patient management team. So I'm going to introduce you how we gross a specimen when we got the specimen from the surgeon. So this is the anatomic picture of the breast and lymph node. You have the areolar complex, nipple, and the breast composed of lobes and ducts, and also you have the lymph nodes. This is a lateral view of the anatomic structure of the breast. In surgery, there are mainly three types of surgeries: lumpectomy, partial mastectomy, segmental mastectomy, excisional biopsies. They all have the common feature that the surgeon takes part of the breast and leave majority of the breast tissue in the patient. Simple mastectomy, skin-sparing mastectomy, nipple-sparing mastectomy, the surgeon will take all the breast tissue out. Modified radical mastectomy is the surgeon will take the breast tissue out as long as some or majority of the lymph nodes. So in this talk, I'm going to focus on lumpectomy and how we examine the lumpectomy specimens. Remember, lumpectomy is the surgeon take a part of your breast tissue out. And simple mastectomy is the surgeon will take a majority of the breast tissue out, but leave the lymph node in situ, that means in the body. And modified radical mastectomy is when the surgeon take the entire breast tissue out and some of the lymph nodes. So lumpectomy generally indicated for patients with early breast cancer, limited ductal carcinoma in situ, that's in situ carcinoma, and usually those patients are treated with, followed with radiation therapy. So here's a specimen for lumpectomy we get from the surgeon. This is just a part of the breast tissue. The surgeon will use the sutures to orient the specimen so that we can know which one is which margin, which is very important for the surgeon and for the patient care. Usually the surgeon will put a double stitch indicating the superior margin and long stitch indicating the lateral margin. So when we have this lumpectomy in the laboratory in anatomic pathology, we'll ink 6 surfaces with different colors so that we can examine the margin status on the microscope. As I said, the margin status is very important for patient care and for the surgeon to decide the following steps. And we'll slice the specimen in very thin slices, generally between 5 millimeter to 1 centimeter thick, to thoroughly examine the specimen. Here's a pictorial illustration of the lumpectomy specimen, and we'll orient the specimen based on the orientation given by the surgeon as the suture indicated. So superior, anterior, inferior, on the back is posterior, and medial and lateral. We usually ink those 6 margins with different colors. Superior, we usually ink with blue because the sky is blue. Inferior, we ink with green because the grass is green. Anterior is usually yellow. Posterior is black, and medial lateral we use a different color. And we slice the specimen with really thin slices so that we don't miss any lesion. And we lay down the slices on the grossing board, grossing table to thoroughly examine the specimen. Again, this is lumpectomy specimen. I just showed a few slides back, and we have inked all these margins. The ink is very important for us to examine the margin status on the microscope. And after that, we slice the specimen really thin so that we can examine all the lesions. For this specific case, we can see there's a mass here in this slice number 2, slice number 3, and slice number 4. On slice number 5, we see this biopsy clip, and this is how the next step for us is to take sections of the lesions so that we can examine them on the microscope to give more accurate diagnosis. For example, here is a mass lesion, and we take the mass along with the posterior margin and inferior margin so that we can know the distance between the tumor to the margin. And after we take the section, we put the section in this cassette. Then we process this tissue and cut them onto glass slides so that we can examine on the microscope. Somehow I can't move my talk. Here we go. Sometimes we use X-ray to X-ray the specimen. As some of you may know that we can identify mass lesions on the gross examination, but for some lesions like ductal carcinoma in situ, the clue is a calcification formation, and we can't really see that in gross examination. Sometimes we X-ray the specimens to identify the calcifications. For this case, after X-ray examination, we see we have the calcification here and calcification here, and those are very close to the margin. And we'll take sections of this lesion along with the margins to make diagnosis of the lesion as well as the distance to the margin. Here's what we see on the microscope. This is DCS, ductal carcinoma in situ. Those are tumor cells still within normal structure. They do not have metastatic potential. And this is the calcification we see on the microscope. And this one is invasive carcinoma. You can see these blue cells, they're infiltrating. They don't have this normal structure anymore. They infiltrate into surrounding tissues and have access to lymphatic channel and blood vessels, and then they have the potential to for distant metastasis. So after all this examination, then we generate pathology report. This is what the patient will see with oncologists or surgeons, and the surgeon and oncologist will explain our pathology report to patients. For example, this one, we make diagnosis of the central lymph nodes. For this specific case, the lymph nodes are negative. Positive versus negative lymph nodes is very important for patient management. And then we make diagnosis of breast. So several things are important for patients' diagnosis and treatment options. The first one is what type of cancer it is. In the breast, the most common cancer are invasive ductal carcinoma and invasive lobular carcinoma. There are many other rare tumors too. Second important information is Nottingham histologic grade. This indicates whether the tumor is well differentiated or poorly differentiated. Poorly differentiated tumor have worse prognosis and will have higher Nottingham grade. Then the size is very important. So for this case, invasive carcinoma measure 3 centimeters. Lymphovascular invasion is very important. This indicates whether we see the tumor cells in the lymphatic channel or blood vessel. Patients with lymphovascular invasion have higher chance for metastasis and worse prognosis. And important for the surgeon is the margin status. So if the tumor is on the margin, most likely your surgeon will have to go back to re-excite that area to make sure no tumor is left in the body. Okay, I think I'll stop here. I hope I gave you some brief introduction on what we do and how we examine the breast specimens, and hopefully this will help you to understand our pathology report.